seconds. Bless you. Okay, so we left off talking about the heart's conduction system, right? And we said that the heart's conduction system was its electrical system. This is the system that starts and distributes action potentials through the heart to tell the heart when it should contract. And we said that we have multiple different parts to the conduction system. We have an SA node here. We've got these internodal pathways, like little roadways that go through the atria and down here to the AV node. From the AV node, we go to the bundle, and then the bundle branches, and then Purkinje fibers. Okay, Purkinje fibers give it to the ventricles, and that's how the stimulus goes. So we're going to kind of walk through this like really slowly, step by step, and add details in so that you guys are super comfortable with the conduction system. So what did we say was the pacemaker of the heart? The SA node. What does that mean when we say it's the pacemaker? It starts the electrical impulse. It sets the pace for the heart, right? The pace that the SA node goes, the rest of the heart's gonna follow, right? So it sets the pace that your heart's going to beat, however many beats per minute you're gonna have. So all of this starts up here at the SA node. So the SA node, remember, spontaneously depolarizes. Why does it do that? It's got leaky what kind of channels? Leaky sodium channels. So sodium leaks into the cell, right? It gets less negative and less negative and less negative until it gets to threshold, at which point it generates an action potential. Why does the action potential spread from cell to cell to cell to cell? Beautiful, gap junctions. The cells are linked by gap junctions. So once one cell depolarizes, it's then going to spread that action potential to all of the other cells, okay? So we talked a little bit about how the cells of the conduction system, their transmembrane potential at rest is about -60. They've got to leak up to about -45 to start that action potential. Okay, so once they leak up to -45, the action potential starts, and again, that happens right here at that SA node. On a side note, we'll see that it's a little bit different in the actual contractile cells. Okay, so we start this impulse at the SA node, and then remember the SA node is going to pass the impulse down to the AV node. We have all of these internodal, so like between the nodes, pathways that bring that action potential or that electrical stimulus from the SA node down to the AV node. Also, if you notice this purple, this is showing you how the stimulus or the action potential is getting spread to the myocardium. Okay, so it's not just staying in these conducting pathways or these conducting cells. It's also getting passed to the actual contractile cells of the atria. And then again, remember, it goes from cell to cell to cell to cell to cell, right? Like dominoes falling. So once we stimulate this cell, it's going to get passed all the way down the atria. Once we stimulate these, it's going to get passed all the way down the atria. So as the SA node fires and sends the signal to the AV node, the atria start contracting, right? And they'll contract like this. So like kind of from the bottom, or from the top down towards the bottom, which makes sense, right? Where are they trying to push blood? Down, right? So it makes sense that they kind of like your toothpaste, right? When you want to squeeze the last bit out, you start at the back and you push it up towards the top. So we're going to start at the top and we're going to push it down towards the bottom of the atria to get that last like 30% or so of blood into the ventricles. So we started, where did we start? SA node. What else do we call that? The pacemaker. We started at the SA node, we went all along the atria, and we got to the AV node. Now, there's a couple really important things here. One, this stimulus, all this purple, notice how it's not continuing down to the ventricles. Hey, there's a cardiac skeleton in place. There's tons of connective tissue that prevents that impulse from being passed from the atria down to the ventricles. We don't want a huge wave to just go completely down the heart. Okay, so it gets passed from cell to cell to cell to contract the atria from the top down towards the ventricles at the bottom, and then it stops because of the cardiac skeleton. When that impulse goes through these internodal pathways and gets here to the AV node, there's a delay. it pauses. When we look at the cells in the AV node, they're not very efficient at passing the signal from one cell to the next. So it takes a little bit longer for that action potential to make its way all the way through the AV node and down to the bundle. Okay, that's not an accident. This is very intentional, because what's happening is that as this action potential is getting spread from cell to cell to cell to cell to cell, we need to allow the cells to actually contract, right? And there's a process involved in that, right? Think back to contraction. The action potential travels, it causes the release of calcium, right? The calcium comes in and binds to the troponin, that removes the tropomyosin, the actin and myosin interact with each other, then contraction occurs. That takes a little bit of time, milliseconds, but time. So we want to allow all of that to happen before we all of a sudden just go, okay, ventricles contract, right? So the atria, we stimulate, the signal pauses or kind of delayed at the AV node while the atria have time to contract, then we pass the signal down. Does that make sense? Yeah, okay. From the AV node, we're going to pass the action potential or the stimulus to our bundle, our AV bundle, which remember enters the septum, and then it splits into the bundle branches. So the left and right bundle branches, which are going to go down either side of the interventricular septum. Again, when you look at this, the purple is showing you the stimulated area. Notice that this is not spreading out to the ventricles like this, right? We're not stimulating the ventricles yet. The actual myocardium of the ventricle has not been stimulated at all yet. We want to make sure that we start it being stimulated down here at the bottom. So we have these components of a cardiac skeleton, all these connective tissue components that separate the tissue inside the septum from the tissue outside the septum, because we don't want to stimulate it yet. We just want to bring the signal down towards the apex. We're going to conduct from the bundle branches over to the Purkinje fibers. Remember we said the Purkinje fibers were all of these little ones at the bottom here? And it's these Purkinje fibers that we'll see in a second actually give the signal to the myocardium of the ventricles. Also, remember right here we have this specialized moderator band, and that moderator band travels over to the papillary muscles. So if you remember this, like the AV valves, how they have these associated structures, right? They have chordae tendineae, and then they have these papillary muscles that secure them. The moderator band we said is like a shortcut, right? It's like a shortcut for that signal so that the signal can get to the papillary muscles, and the papillary muscles can contract and hold really strong onto this valve before the ventricle actually contracts and before we actually put force on that valve. So where did we start? The SA node. What else do we call that? What? Okay. From the SA node, what node do we go to? The AV node. What happens at the AV node? There's a delay. We pause, right? While we're pausing, what's happening up in the atria? They're contracting. From the AV node, we go into the septum, into the AV bundle, then the bundle branches, and that's going to bring us down towards the apex of the heart. Okay, and we said that the bundle branches would pass the signal to the Purkinje fibers. Again, it's these Purkinje fibers at the apex of the heart that are going to pass the stimulus to the myocardium of the ventricle, okay, to the actual contractile cells of the ventricle. So we have not told the ventricle to contract until we get to the bottom to those little Purkinje fibers. Okay, this is really important because then what we see is that, so we stimulate it down here first, and then remember the signal gets passed from cell to cell to cell, right, through all of their gap junctions. So we see that the myocardium of the ventricles tends to contract like this. And where do we want to push the blood out? Where are the arteries? Up here, right? They're up towards the top of the ventricles. So it makes sense that we want to start our contraction down here and squeeze up towards them. right? And all the cells are going to contract in this perfect little pattern almost all together, but so that they're squeezing up and out like that. And then that pushes the blood up and out of these arteries. Again, imagine if we stimulated them from the top right away. Right? We didn't go into the septum, we didn't go to the Purkinje fibers. If we just said, okay, here you go, they would do that. Right? But the blood has to go out up here. So that makes no sense. That would be so, it just wouldn't be efficient. Just squeeze like this and then have the blood bounce down and around, and it would mess everything up. So it makes sense that the signal goes down to the bottom of the apex and then passes to the myocardium so that the ventricles contract from the bottom up towards the top, which is where they actually eject blood. Okay, and how is it that we pass the signal from cell to cell to cell? Through gap junctions.
I have a question.
Mm-hmm.
So the junctional rhythm, like the cardiac rhythm, junctional rhythm, is that because the septum don't release all the blood?
Because the septum doesn't release all the blood?
Yeah, you said septum, like the brain.
The septum is the wall in between the two ventricles.
Okay.
So the blood's actually in the ventricles.
I'll talk to you.
Okay. Here we see that happening. So we pass the signal from the Purkinje fibers to the ventricles, and then you can see as the purple spreads up, this signal gets passed from cell to cell to cell to cell, and the ventricles are actually able to contract. Okay, the atria have already contracted and relaxed, and the ventricles contract, then they relax, and the whole thing is over. So we said that the SA node was the pacemaker of the heart, and however fast the SA node stimulates the heart, that's how fast the heart's going to beat, right? Everything else follows suit. Starts at the SA node, and then it spreads to the whole rest of the heart. So that generates the pace that our heart's going to beat. Of course, things can always go wrong, right? Or things can always be different. And we can get really slow heart rate, we can get really high heart rate, and that's called bradycardia and tachycardia. Brady means slow, cardia means heart. So bradycardia is an abnormally slow heart rate. Most things will define this as a heart rate less than 60 beats per minute. Tachy means fast, cardia means heart. So what's tachycardia? Fast heart rate. Most things will define that, or most sources will define that as a heart rate over 100 beats per minute in textbook. My kind of a caveat here though is that this is all relative, and depending on the patient and depending on that patient's physical characteristics, their normal heart rate might be really, really low. So athletes, for example, like triathletes, long distance runners, naturally have a very, very efficient cardiovascular system. Their resting heart rate is normally relatively low. So they might look bradycardic. They might look like their heart rate's really low, but that's actually normal for them. So you kind of have to take the patient into account before you're like, oh my gosh, why is their heart rate so low? That might be their normal. Again, like long distance type athletes, like endurance athletes. An ectopic pacemaker occurs when something besides the conducting system or something besides the SA node is taking over as the pacemaker for the heart. This word ectopic is telling you that something's in the wrong place. So like an ectopic pregnancy occurs when the fertilized egg is not implanted in the uterus, instead it's in like the fallopian tube, right? It's in the wrong place. An ectopic pacemaker is when the pacemaker is in the wrong place. So instead of the SA node up at the top, firing rhythmically and starting each impulse for each heartbeat, another cell starts firing really, really rapidly and takes over. Because remember, whatever's going the fastest is going to end up spreading the impulse to everyone else. So the whole heart's going to follow whatever cell's beating the fastest, right? Or whatever cell is generating action potentials the fastest. So when we have an abnormal cell, like we could have something down towards the apex by the Purkinje fibers, generating impulses really, really, really rapidly, everything else will follow suit. This decreases the efficiency of the heart greatly because one, it's going way too fast. When the heart's beating way too fast, it doesn't have time to actually fill up fully with blood and eject it fully. Also, you have these weird patterns going where the heart's not beating or contracting in the proper order, right? If you're generating an impulse from the bottom and then it's kind of spreading up and going in all these weird ways, like you're not actually squeezing the last of the atrial blood to the ventricles. You're not fully contracting the ventricles in the right order. Okay, so it really messes up the efficiency of the heart. We'll talk a tiny bit about an EKG. An electrocardiogram, which we call EKG or ECG, is a way that we can record all of the electrical events that are going on in the heart. Right, so essentially all of this stuff that's happening in the conduction system, right, that's electrical events. So we see a couple different things when we look at the electrical events in the heart. We see how big of an impulse it is, right, how much of an electrical impulse is this, and then we can also kind of look at the pathway that the electrical impulse is taking, which direction it's moving as it goes through the heart. When we look at an EKG or an ECG, what happens is we convert that information to an actual graph. And then you can look at the graph. You can look at the different waves. You can look at the size of them to see how big the impulse is. And you can look at the shape of them to see if it's taking the right pathway. Typically, well, there's all different patterns that you can put the electrodes in, but typically the electrodes are going to be placed across the torso area and sometimes out into the shoulders. And again, we'll look at that recording, or we'll look at that graph that prints out, and we can diagnose rhythms that are messed up. Okay, so when there's like arrhythmias and weird heart rhythms that are occurring, and then also myocardial damage. So like if there was a lot of damage to the ventricles, you can look at the EKG and see that on there. So again, you can get super in depth, and it's kind of a complicated concept or a complicated topic, but we're going to just kind of brush the surface of it. We'll look at a few of the key features of the electrocardiogram. So the P wave is a relatively small wave that looks like that, a small positive wave that goes up, and that signals atrial depolarization. Remember, depolarization is like the stimulus, right? That's when you stimulate the cell. So when we depolarize the atria, what's going to happen in them? What are they going to do? What's up? Less negative, but then they contract, right? When you stimulate them, they contract. So the P wave, when atrial depolarization occurs, is going to tell us something about the atrial contraction. After that, we'll have some time pass, and then we have the QRS complex. Okay, the QRS complex is stronger. It's a lot stronger of a signal, an electrical signal, which means it looks bigger on the graph. It's also a more complex signal. What I mean by that is that the shape is odd. Okay, and the reason the shape is odd like that is because the path that the stimulus is taking is varied. It's kind of an odd path. It changes direction a bit as it goes. As we go down into the septum and then down around the Purkinje fibers, then up through the ventricles. Okay, that's a weird pathway. And whether or not the graph is going up or down depends on if the impulse is going towards the electrode line or away from the electrode line. So anytime you're kind of changing direction in your pathway, you're going to have a varied signal. Okay? This QRS complex is showing us ventricular depolarization. So what are the ventricles doing when they get depolarized? Contracting. Okay, so here with our P wave, we're going to stimulate the atria, they're going to contract. A little bit later, we see our QRS complex, we're going to stimulate or depolarize our ventricles, they're going to contract. And then at the end, we see a little T wave. The T wave, again, is a relatively small, simple signal, and that is showing us ventricular repolarization. Okay, so we're repolarizing our ventricle now. So when the ventricle repolarizes, after it contracts, what's it going to do? It's going to relax. So we see atrial contraction, ventricular contraction, ventricular relaxation is happening right around here. Why don't we see something for atrial contraction? Atrial relaxation. Beautiful. It is a small signal, and the QRS hides it. It's happening right now. So those electrical changes are kind of absorbed into the signal, if you will. Like you can't see it because of all of this major activity that's happening in the QRS complex. There are also numerous intervals and segments which have to do with the timing of the depolarizations and repolarizations and the intervals between them. But we're not going to go into it. We don't have time and we don't really have a need at this level to go into it. But just so that you're aware, like the intervals, the segments, this is all about timing. Okay, so how long it's taking for, in between atrial depolarization and ventricular depolarization. How long does it take between ventricular depolarization and repolarization? All of that's going to be in your segments and your intervals. So this is showing you the printout from the electrocardiogram. This is just kind of blown up a little bit with labels. Again, you can see that this is time. Okay, so on the vertical axis is time. This is showing you how much time is in between each of these events. And then amplitude, or how strong the signal is going to be, sorry, I think I said vertical when I pointed to horizontal, did I? Okay, stop me when I do stupid things. On the horizontal axis is time. On the vertical axis, this is showing you the size or amplitude of the signal. And then again, whether it's positive or negative has to do with whether it's moving towards or away from certain electrodes. But here you see a little P wave, okay, for when the atria depolarize, after which, of course, they're going to contract. You see the QRS complex, which is when the ventricles depolarize. Did I put that anywhere? Here it is. Where the ventricles depolarize, and then again, that's going to lead to ventricular contraction. And then here you see another little wave, which is the T wave, and that's just corresponding to the ventricles repolarizing, so going back to their resting negative state, and that's when they're going to be relaxing. And again, you should see nice pauses in here. So we're just going to look a little bit at some abnormal EKGs. This isn't really something you'll be tested on. I mean, you'll see on the study guide, I think I asked you like one very general question, like comparing AFib to VFib. But this is just kind of for your information, just to look at it a little bit and kind of see. So looking at this, the first one, PACs, are premature atrial contractions. Okay, so that's pretty self-explanatory, right? The atria contract too soon, sounds like. So looking at this, what does the P wave tell you? The atria contract, right? So you see the P wave, you see the QRS complex, which is when what happens? The ventricles contract, and then you see your T wave, which is when what happens? Ventricles relax. And then you see a nice pause, and then the atria contract, the ventricles contract, the ventricles relax. Holy Lord, right? There should be a nice period of time here. But look how quickly the atria are contracting. That's premature. Okay, so premature atrial contractions. These are kind of random events. They happen to all of us every once in a while. Not a huge deal if it's just one. So if all of us walked around with our heart being monitored all the time, every once in a while, we'd get a PAC, whatever, just happens. Now, if we have multiple PACs in a row, if it keeps happening for some reason over and over and over, then you're going to see paroxysmal atrial tachycardia. What did we say tachycardia was? Fast heart rate. So now you have a really rapid heart rate that's continuing because of what's happening up in the atria. So the atria are beating really fast and everything else is following suit. Okay, the atria contract, ventricles contract, atria contract, ventricles contract. So we can see that on here, right? This would be a normal, right here. But then look here, atria, ventricles, atria, ventricles, atria, ventricles, right? Super, super fast. It's tachycardia because the ventricles are keeping up, right? The atria are starting this really rapid rate, but the ventricles can keep up with it. So the whole heart beats really, really rapidly. It's not as efficient like that because it doesn't really have time to fully fill nicely, but you know, it happens. Atrial fibrillation occurs when, if you look on here, see all of this craziness, just brrr, and then you see ventricles, brrr, ventricles, brrr, ventricles. What happens here is the atria are literally what we call fibrillated. They're quivering. They're being stimulated so fast that they're not actually beating correctly, and the ventricles can't keep up. So you don't see atrial contraction, ventricular contraction, atrial, ventricular, atrial, ventricular. The ventricles cannot keep up with the atria. It's too fast, so they say, never mind, whatever. Because what can take over if the SA node is not the pacemaker? What else can be the pacemaker? The AV node. So they can just say whatever and rely on the AV node. Okay, now would the heart rate be faster or slower? It would slow down in that case because the AV node spontaneously depolarizes at a slower rate. You can live with AFib. A lot of people live with AFib. Some elderly people don't even know they have AFib. It decreases the efficiency of the heart, but remember, as the heart's filling, the ventricles fill to about 70% of volume without the atria contracting. So you're still going to fill your ventricles, and it's your ventricles that have to contract to pump blood to the lungs and to the body. So you can live with AFib. Again, some elderly patients that don't move around very much might not even realize it that much. They would get tired faster with physical activity, but they might not even realize it. There are issues with it. Clots are a big issue. We see that they throw clots more frequently than other patients, so we typically put them on some sort of a blood thinner to prevent that, but you can live with AFib.
So a TE isn't necessary for AFib?
A what?
TE?
What's that?
Transesophageal
No. Sorry, I don't know why I was thinking clots for some reason. I'm like, God, is that a filter for clots? I don't know what that is. No, you don't have to. Okay, so PVCs are premature ventricular contractions. So here you have your P wave for your atria, your QRS for your ventricles, depolarizing, and then they repolarize. And then look, all of a sudden your ventricles went again. It should be atria, ventricles follow, right? Atria, ventricles follow. But in this case, right after your ventricles repolarized, they just depolarized again, prematurely. Was not supposed to happen then. PVCs happen, not commonly. You shouldn't be having them a lot. But at some point, I guarantee you, you've probably had a PVC. Just if it's just one of them, it's kind of a random thing, okay? Kind of like the PACs. The premature atrial contractions. Now, if we have multiple PVCs in a row, then we have ventricular tachycardia. Okay, so we have tachycardia, it's a rapid heart rate, but it's because of the ventricles. It's not the atria going really fast and then the ventricles following. It's the ventricles causing this. Okay, but the ventricles are still working. This is a problem. This is signaling that there's something majorly wrong, and you should probably get on it. This is VFib. So what did we say? Fibrillation was, or AFib was when the atria kind of quiver, right? They're trying to go so fast they can't work. VFib is when the ventricles do that. Okay, that is not good. You cannot live with VFib. When someone goes into cardiac arrest, right, they're in VFib. So if you look here, do you see any nice QRS complexes? No. The QRS complex is when the ventricle is able to pump blood. So with no QRS complexes, your ventricle is not pumping blood. You're not oxygenating your blood and you are not sending it out to your body. Okay, that is not okay. Major differences between the AFib and VFib because of that. Because remember, the atria are just receiving chambers. The ventricles are your pumping chambers. Okay, so that's when you're gonna need to shoot some epi and shock them. Okay, God, I'm taking way too long. Okay, so that's it for conduction. Okay, the conducting cells.